Hi, I'm Dr. Sheryl Martin-Schild. I am your statewide stroke medical director for the Louisiana Emergency Response Network. This educational video is intended to provide information and instruction for EMS necessary to safely transport stroke patients between a spoke hospital and a higher level stroke center after or during treatment with TPA. We'll start by explaining the importance of the neurological assessment during transfer. The chance of experiencing a neurological deterioration is greatest in the first 24 hours after stroke. This is when most transfers are taking place. For patients with intracerebral hemorrhage, the volume of hemorrhage increases in the first few hours, and so does the risk of extension into the ventricles. As volume increases, mass effect and raised intracranial pressure become more likely. Blood extending into the ventricles increases the risk of hydrocephalus. Mass effect, raised intracranial pressure, and hydrocephalus typically result in depression of consciousness, dilatation of pupils, and reduced ventilation. The recommended head of bed position for a patient with intracerebral hemorrhage is 30 degrees. Raising the head of the bed is the fastest way to reduce the intracranial pressure. Monitoring a patient with intracerebral hemorrhage during hospital transfer is essential to recognizing neurological deterioration as soon as it happens and introduce treatments which would give a deteriorating patient the best chance of survival. Notifying the physician at the higher level of care, the secondary destination hospital, that a patient with intracerebral hemorrhage has deteriorated is essential to the receiving hospital, recommending treatment during transportation, and being prepared to immediately address the cause of the deterioration. Treatments during transportation may include administration of medications to change the patient's blood pressure, or may mean stopping for intubation and hyperventilation to control the airway and treat the suspected raised intracranial pressure. The receiving hospital needs to be prepared to emergently re-image the patient with CT scanning and may mean placement of an external ventriculostomy drain to decompress hydrocephalus or even emergent neurosurgery. For patients with ischemic stroke, risk factors for neurological deterioration are advanced age, large vessel occlusion, and TPA use. TPA increases the risk of neurological deterioration through the mechanism of symptomatic hemorrhage. While this is uncommon, occurring in less than 3% of patients who receive TPA, the consequences are significant and emergency treatment may be necessary. Again, the receiving physician needs to know that a patient's condition has deteriorated or improved during transportation to be prepared to quickly address the patient's needs. The receiving physician has a plan of care in place when he or she accepts a transfer, based on the information available and the expected condition of the patient. The plan may be admission to the ICU for monitoring, enrollment in a clinical trial, or going to the cath lab for thrombectomy. If the plan needs to change, the earlier the receiving hospital can anticipate this, the better the chance the patient will get what they need when they need it. Having the immediate contact information for the receiving physician is crucial to the time-sensitive communications necessary to maximize the safety of the patient being transported between the two hospitals. This portion of the acute ischemic stroke post-thrombolytic EMS inter-hospital transfer guideline must be complete before a patient leaves the sending or spoke hospital en route to the receiving or hub hospital. This sets the expectation for a time TPA infusion is completed, since the infusion is supposed to complete 60 minutes after it starts. It is very important that the waste is discarded. What does this mean? This means that every drop of the TPA bottle that does not need to be administered is removed from the vial. Removing this waste prevents overdosing the patient if there is a pump failure, and prevents confusion over whether there should be anything left in the vial. The time of TPA infusion completion should be documented. At this time, start infusion of normal saline at the same rate via the TPA tubing, but not to exceed 1 liter. If TPA infusion was completed before the handoff between sending facility and paramedic team, this should be completed by the sending facility. If the infusion completes during transfer, it is expected that the time of completion be recorded by the paramedic en route. After the pump stops infusion, there are several milliliters of TPA remaining in the tubing, In order for the patient to receive the full dose, it is necessary for normal saline to be infused through the TPA tubing. The maximum rate of TPA infusion would be 81 cc's per hour. This infusion rate for normal saline is expected to be safe for most patients. If at any point during the infusion of normal saline there is concern for the patient being in a volume overload state, contact the receiving physician. Let's talk about the pharmacology behind the therapeutic interventions. Reviewing the acute ischemic stroke post-thrombolysis EMS interhospital transfer guideline will facilitate discussion of the pharmacology behind the therapeutic interventions recommended during transportation. While evidence is limited, most studies have found support for the head of bed flat position to augment cerebral blood flow in patients with ischemic stroke. This being said, if there are concerns for airway protection and secretion management, particularly in a bumpy ambulance ride, it is reasonable to place the head of the bed at 30 degrees. Complications of TPA include orolingual angioedema, rash, systemic bleeding, and brain bleeding. Angioedema usually occurs during the TPA infusion. The lips and tongue should be examined every 15 minutes or with a patient complaint of new symptoms. The most typical pattern is hemiorolingual angioedema, which is when one half of the tongue gets swollen. Many patients think they have bitten the side of their tongue. If TPA is still infusing, this needs to stop. There is a small chance that the swelling will progress and require placement of an oral airway, sometimes an endotracheal tube to maintain patency. The receiving physician needs to be alerted if this occurs, so that they can have medications immediately available to treat the angioedema and anticipate the possibility of intubation. The risk of angioedema is higher in patients taking ACE inhibitors. Only rare cases of rash with urticaria have been reported. This should be monitored for developing anaphylaxis. The ABCs do need to come first, but the risk of administration of epinephrine is a serious rise in blood pressure. The accepting physician should be informed of the patient's blood pressure before and after the angioedema or new rash was noted, so that he or she can make a decision on the risks and benefits of epinephrine administration based on the severity of the angioedema and change in blood pressure. If systemic bleeding occurs, the paramedic should contact the receiving physician. He or she will likely recommend application of direct pressure whenever possible. If bleeding cannot be controlled with direct pressure and TPA is still infusing, the receiving physician may ask that the TPA infusion be stopped. Because the half-life of TPA is only 4.5 minutes, within 30 minutes of completing the infusion, the bleeding should subside. If bleeding can be controlled with direct pressure, the receiving physician may opt to continue the TPA infusion. Communication is key. Brain bleeding will typically present with one or more of the following symptoms and signs: a new headache, neurological deterioration, as defined by an increase in the mini NIHSS by at least 2 points, nausea and vomiting, hemodynamic instability. Brain bleeding should be suspected if any of these symptoms develop during transportation. Any of these changes should be reported to the receiving physician so that he or she can be prepared to emergently evaluate the patient for evidence of bleeding on CT scan. Because a patient being transported during or shortly after TPA is unlikely to have been formally evaluated for dysphagia, the patient may be at high risk of aspiration. After development of nausea and vomiting, treatment of nausea is indicated. Intravenous administration of ondansetron is preferred over promethazine due to the sedating properties of promethazine. If the patient became sedated, the sensitivity of the neurological exam would be compromised, and therefore the ability to detect a neurological deterioration would be reduced. You should confirm that you have adequate quantities of medications to treat blood pressure for the full anticipated transportation time. The American Heart Association guidelines provide a threshold blood pressure and recommendations to lower blood pressure before and for 24 hours after TPA administration in patients for whom the blood pressure exceeds this threshold. There is a correlation between brain bleeding and uncontrolled blood pressure. The specific agents recommended by the American Heart Association guideline are intravenous and topical treatments. Because intravenous agents have faster onset and oral intake is not recommended in the hyperacute setting of stroke. The preferred agent is nicardipine, but this may not be available in the sending hospital or spoke. Or blood pressure exceeding the parameters may have developed while en route without sending nicardipine due to no anticipated need. The most frequent complications of nicardipine are reflex tachycardia, which is rarely life-threatening, or symptomatic hypotension. Hypotension can be avoided in most cases by slowly escalating the dose by 2.5 milligrams per hour every 15 minutes up to a maximum dose of 15 milligrams per hour. Available studies suggest nicardipine is superior to the primary alternative, labetalol, in terms of maintenance at goal blood pressure and less variability in response. Labetalol is most frequently limited by bradycardia, since this is a beta blocker. Even though nicardipine is a calcium channel blocker, it does not work on the receptors which result in slowing of the heart rate. Other agents, including hydralazine IV and nitropaced transdermal, are reasonable alternatives if nicardipine is not available, is at a maximum rate and more blood pressure lowering is necessary, and the heart rate is less than 65 beats per minute. It is very important that your ambulance is equipped with a sufficient supply of blood pressure lowering medications prior to departure with a patient who has received TPA. The sending facility should provide the medications if any antihypertensive was used at that facility to treat blood pressure. Running out of a medication which has been controlling the blood pressure can be very dangerous, as the rebound can lead to life-threatening blood pressures. Hypotension is associated with worse outcome in patients with stroke. When the blood pressure is low, the cerebral perfusion pressure is low. The penumbra, or ischemic brain that isn't dead yet, is dependent on blood flow. While normal brain can auto-regulate to maintain blood volume, ischemic brain is dependent on blood pressure to maintain flow. A drop in blood pressure compromises blood flow through a partially blocked artery and through collaterals, arteries providing supplemental blood flow to the ischemic brain. If hypotension develops, this needs to be treated. The first-line treatment should be small boluses of normal saline. If hypotension persists, the receiving physician should drive further orders. Untreated hypotension threatens the recovery of the patient. Hypoxemia is very bad for the ischemic brain. Optimal oxygen parameters have not been well established, but supplementation to a threshold at least 92% is considered safe and adequate to meet the oxygenation demands of the brain. The Q15-minute frequency of vital signs and neurochecks is recommended by the Brain Attack Coalition and the American Heart Association, American Stroke Association. The safety of patients being transported between facilities after TPA is dependent on communication, monitoring, and responding to changes in vital signs and neurological examination. Let us now review the NIHSS examination and the mini-NIHSS assessment. The mini-NIHSS is simply the very first few components of the NIHSS examination and the motor component for each limb. Level of consciousness 1A is the level of alertness. This is scored from alert, scoring 0 points, to comatose, scoring 3 points. Level of consciousness 1B assesses the patient's orientation, specifically to the current month of the year and the patient's current age. The patient scores 1 point for each incorrect answer on the first try. Remember to ask the questions in this order. Otherwise, after reporting age, many patients with deficits in attention will give you the month of their birth, rather than the current month. Level of consciousness 1C assesses the patient's ability to follow commands, specifically, close and then open your eyes, and make a fist and then open your hand. It is okay to demonstrate the action. For motor, each limb will be assessed individually. Motor in each arm and leg will be assessed. With the arm, it should be held at 45 degrees for 10 seconds, and the leg held at 30 degrees for 5 seconds. 0 scores no drift for the full count. A 1, the patient drifts, but the arm doesn't hit the bed before the full count. Someone who scores a 2 will have some anti-gravity, ability to get the elbow up off the stretcher, but cannot sustain anti-gravity for the full count. Someone who scores a 3 has some movement, but cannot lift the arm against gravity, and someone who scores a 4 has no movement at all. Our patients depend on the knowledge and expertise shared between facilities and paramedics.
someone call 911?
Yeah, we did. This is Vanessa, my coworker. I think she may have had a stroke.
Hi, Vanessa. I'm Amy. I'm going to be taking care of you today. How old are you, baby?
27.
Is that right?
That's correct.
Okay. Let us help you. We're going to get you on our stretcher. We're going to check you out a little bit more. We're going to have a seat right here. You just lay flat for just a moment, okay? Can you close your eyes for me and open them back up? All right, can you smile real big for me? Okay, wonderful, good job. Can you make a tight fist for me? Tight as you can. Okay, open it back up. Okay, good job. Can you make a fist for me? Tight fist with your, real tight. Okay, open it back up for me. Okay, wonderful. Now with this arm, we're gonna raise it up to about a 45-degree angle right here. I'm gonna let go and I want you to hold it in this spot right here while I count to 10, okay? You ready? 1, 2, 3. All right, good job. Let's do the same thing with this arm right here. We're gonna hold it right here and we'll count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You can relax it. With your left leg, we're gonna hold it up to about a 30-degree angle. I'm gonna let go and we're gonna count to 5. Ready? 1, 2, 3, 4, 5. Good job. You can relax it. We're gonna do the same thing with this left leg. You ready? I'm sorry, your right leg. 30-degree angle, we're gonna count to 5. 1, 2, 3, 4, 5. Good job. Doing the mini stroke exam, even while transporting, is simple and easy to do. Miss Vanessa, we're gonna do some of the same stuff that we done inside, okay? I'm gonna ask you some of the same questions. Can you tell me what month we're in?
May
And how old are you?
27.
And can you close your eyes for me? And open them back up? Okay. Make a tight fist and open it back up. Wonderful. Now while we've got this arm up at the 45-degree angle, I'm going to let go and I want you to hold it up while I count to 10 again, okay? Ready? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good job. We're going to do that again with your right arm. We're going to let go and we're going to try to count to 10. Ready? 1, 2, 3. All right, baby. Just going to count to 5. Ready? 1, 2, 3, 4, 5. Okay, you can relax it. And the right leg. Ready? 1, 2, okay.
Amy, I've called ahead for pre-hospital notification.